Welcome to They Didn't Teach Us This in Sex Ed, the official podcast from the Society for Reproduction and Fertility. Did you know that Polycystic Ovarian Syndrome is not actually characterised by ovarian cysts? It's a metabolic condition that affects much more than just the ovaries. And joining me today to tell me all about it are Professors Colin Duncan and Mick Rae. They'll explain why PCOS is now called PMOS, which stands for Polyendocrine Metabolic Ovarian Syndrome. They'll also tell us about how early fetal life influences development of PMOS, what options are available for women, including the potential benefits of GLP-1 based medications like Mounjaro or Ozempic. We'll also find out why sheep are an excellent animal model for research in reproductive health in humans. Welcome, Professors Colin Duncan and Mick Rae. So your specialist subject, or one of, is Polycystic Ovarian Syndrome, which as of just last week is no longer called Polycystic Ovarian Syndrome. So Colin, can you tell us a wee bit about PMOS, what it means and why the name change has happened?
Yeah, I mean, one of the things about polycystic ovary syndrome is that it doesn't have any cysts in the ovary. And I think a lot of patients get very confused, okay? And to be honest, it's not all about the ovary, okay? And so PMOS is the new name for it, and that's called Polyendocrine Metabolic Ovarian Syndrome. And it highlights the fact that it's more than just the ovary, and there's a metabolic component, but it's not that much different from PCOS to PMOS, which allows, obviously, sort of patients to still understand it. But it's going to be a tough thing for people to shift over from PCOS to PMOS. But the crucial thing is that people focus on cysts, and there's no cysts in the ovary in PCOS or PMOS. There's just little paused follicles, little paused eggs in the ovary because the ovaries got confused.
Well, that was quite surprising to me, and obviously I'm a reproductive biologist as well. It's no my specialist area, and I completely thought that there was cysts or, maybe growth of multiple follicles or more than normal amounts of follicles, which is usually the wee sacs in the ovary that contain the egg. So is that not true either in terms of the numbers of follicles?
Well, the number of follicles are increased.
Right.
And the question is that why are they increased? And we know that every month follicles start to grow, and then some of them will grow and release, and other ones will wither away. And in PMOS, the follicles start to grow and then they pause. And so therefore they don't wither away as quickly, and therefore you get this build-up of follicles.
Right.
But in each of these little things that were called cysts, because we didn't know there were little pause follicles, there's a healthy egg, and that's why women who have PMOS, who undergo IVF, get huge numbers of eggs, collected, because there's all these little paused eggs that can be reactivated.
Right. And it seems like there's been quite a big concerted effort across the globe to drive this name change. Were you as part of that, or has your research fed into that, and what do you think it means for the patient population?
Well, I mean, I think that the good thing about that is that it was led by Australia, and it involved experts from all across the world. But the crucial thing is it involved patient groups and people with lived experience, and they were telling us that they wanted to have the name changed because they didn't understand it. And often the doctors they saw talked about cysts in the ovaries. Okay, so it was driven by both researchers, clinicians, and importantly, patients.
Yeah. So what actually is PMOS then? If it's no about cysts in the ovaries, what is the symptoms? How would somebody maybe recognise that this was something they might want to talk to their GP or other doctor about?
Well, the thing about the diagnosis means that you have to have these little paused eggs in the ovary, you have to have irregular periods, and you have to have signs of increased male-type hormone, because these little paused follicles produce a little bit extra male-type hormone, and therefore the symptoms relate a little bit to that, the irregular periods, or no periods and then very prolonged bleeding. And extra signs of that little male-type hormone. You might have extra hair on your chin or lose a bit of hair on that. But more importantly, because of the metabolic side of things, which is not part of the diagnosis, but it's there, women with PMOS have got a higher level of the hormone of storage. And so they're very good at storing and not using. So what does that mean? Well, it means that they find it easier to gain weight, harder to lose weight, and they find that because they're storing, they have less energy, so they feel tired. They find that they don't respond to diets the same way that their friends and family and colleagues do. And so therefore there's a higher prevalence of, say, eating disorders or psychological issues because their body is not working in the same way. And there's a hormonal element to that and a metabolic element to that. And metabolic is how you deal with food.
Yeah, and I know you were part of a group that published a big study, was it last year or early this year, looking at the kind of treatments that people might expect and what treatments might be effective. So what would be the recommended treatment protocol?
Well, with regards to treatments, then you've got a holistic approach, you've got a hormone approach, and you've also got a metabolic approach. The thing about the treatment is there's nothing that's going to say take this and it's all going to go away. So what you have to do is treat the problem that presents at the specific time. So if somebody is not growing and releasing eggs, they might come to me for fertility. And the reason that the treatment for fertility issues is totally different from the treatment of, say, having spots or extra hair, which is totally different from the treatment for increased weight and things like that. So the treatment varies. Often, because of the hormone imbalance, one of the common treatments is the combined oral contraceptive pill, because the hormones will be switched off. The male type hormones will be lowered, and therefore generally people will improve because their hormones will be very similar to other people's hormones. But that doesn't have the same impact on the metabolic side of things, so you have to mix and match different types of treatment.
Yeah, and I guess you're hearing more in the clinics about GLP-1s. They seem to have taken the world by storm. And thinking about the metabolic side of things, is GLP-1s like Mounjaro and Ozempic, are they part of the protocol?
Well, one of the crucial things is because women with polycystic ovarian syndrome have that metabolic imbalance, they are more prone to having weight problems with obesity, and they're also struggle to lose weight. And we know that weight gain in polycystic ovarian syndrome, or PMOS, makes it worse. So it becomes this vicious cycle. And we know that losing weight can improve fertility, it can improve the skin, it can improve the metabolism. So losing weight is really, really crucial in people who've got weight problems in polycystic ovarian syndrome. But the problem is that they don't respond the same way to diet and exercise as women without that metabolic imbalance. And the question is, how can we help? Now, GLP-1 agonists, or the combined GLP-1, GIP, such as Mounjaro, they're good because what they do is that they help people lose weight. And one of the big reasons they make people lose weight is they affect their appetite and their cravings for food. And one of the biggest issues with polycystic ovarian syndrome is that people don't eat more than anybody else. So they don't often have the same cravings. Now, the crucial thing is that the GLP-1 agonists do work in polycystic ovarian syndrome, and that's good. My anecdotal experience, and this hasn't been done by research, is the patients tell me it doesn't work quite as well as it does if they didn't have the polycystic ovarian syndrome.
Right. So there are different available options, and I guess it's treating or addressing the issue that's most prominent for each individual patient.
Yeah. And GLP-1 are a major new treatment in the area. Although certainly locally in Edinburgh, people with PCOS don't get access to that on the NHS. Hopefully that's going to happen soon, but there's a lot of people having to source things privately, which is very sad.
Yeah. Now, you two have done a lot of work over the years in actually understanding what drives the development of PMOS, and I know yourself, Mick, you've worked a lot with Colin on the sheep model. So what have you been trying to focus on in your research to work out what's underlying this?
Well, if I wind back A long time. My background was the fetal origins of adult diseases, and we used sheep as models for that, and that tended to be very metabolically based, looking at the development of various metabolism systems. And so, having also a background in the ovary, I was really, really delighted to combine both and start working with Colin. However, in all those years, I never got the chance to work on an ovary. Because, and actually, this is why I like the new name. In our work with sheep, where we recreate PCOS or PMOS in the sheep, we've worked on the pancreas, we've worked on the liver, we've worked on the adrenal, basically the powerhouses of metabolism, and it really, I guess, what I think we've managed to do in a small way is integrate various metabolic organs, like the ones I've just mentioned, with the reproductive system. And to some degree, I guess, the fertility, the reproductive parts of PMOS, at least some of them, may actually be victims of the altered metabolism. But for me personally, just the opportunity to have a clinically relevant paradigm to work in that shows how the early life experience can configure our health trajectory to some extent or another for the rest of our lives has just been fantastic.
So what kind of has been your most interesting, or what findings have you thought, wow, like that's changed how we think about things, particularly when it comes to the fetal origins of PMOS?
Whether it's changed how anyone else thinks about things, I have no idea. But for me, the whole story of insulin resistance developing, and so if your insulin isn't doing its job particularly well to tell cells of your body to uptake glucose that's been absorbed from your gut, then you need more insulin to get your glucose concentration correct. And so we know that excess insulin is always a consequence of insulin resistance, except for in our models, excess insulin occurs before insulin resistance. And for me, that's been the most interesting thing, because I had to rethink what high insulin means. And maybe the high insulin is actually one of the promoters of insulin resistance. But the critical thing for me is that insulin, the hormone of storage, as Colin described it, sits right down the middle of all of this. Insulin has impacts upon the ovary in terms of the excess production of male-type hormones from the ovary. It has effects on our adipose tissue. So I think, for me, the early days work we did on the pancreas really opened my eyes hugely that PMOS is such a multi-system situation, that incredibly complex beyond me. But I think we've contributed bits and pieces along the way, and we've also contributed in terms of there are reports of male effects. So boys born in the same way as women are born with PCOS, born with an altered metabolism reminiscent of PMOS, but sex-specific nonetheless. So that certainly came from reports in the human literature, the clinical literature, but also we've been able to phenocopy or drive that into male sheep as well, and being able to examine them and see what's making them tick too. So
is there something happening in utero to fetuses, or are they exposed to something that's driving this during their very early development?
Well, in our models they are, because we give them a little bit extra male-type hormone, and that is sufficient. One adjustment of one hormone is sufficient to recreate so many of the aspects of PMOS in the next generation. And for me, that's the mind-blowing thing, is that that's only one hormone, and we are exposed to so many, and we're exposed to so many different things that could be disrupting our developing fetal endocrinology or maternal endocrinology or placental endocrinology. Quite frankly, we're all products of this early life existence. And I think it's fascinating. It makes us all who we are.
It is totally fascinating. And I think by doing this podcast, the more people I talk to about different aspects of reproduction and fertility, I'm learning that the fetal origins are much more important than maybe we think about. And also this concept of things like PMOS and endometriosis being whole body diseases, whereas we've always kind of focused on them as something that happens in the reproductive tract and the reproductive tract alone.
I can remember back in the 1990s submitting a paper to a journal for review talking about maternal conditions and how that had an effect on the offspring's ovulation rate, and actually getting the paper rejected because the reviewer had never heard of anything so magical. And you fast forward 3-4 years later, and it's an acceptable thing to say.
And now we're even talking about potential grandparents.
Yes.
Effects on the multi-generational effects. So how did you two come to be working together?
Well, I think that when it comes down to research that matters, I think that there's a perfect combination of clinicians and scientists that can work together.
You're the perfect combination.
And I think that because what happens is that the scientific rigor that discovery scientists bring is exceptional, and we as clinician scientists bring that knowledge, that clinical knowledge of the condition, and more importantly, what matters. And nowadays, in that triangle, there's the patient as well, and they're linking in. And I know that Mick and I have had some links with some PCOS or PMOS now charities to get a feeling for what the patient lived experience is.
Yeah.
But I think that, and how we came together was that we're both working essentially on the ovary, and Mick had already been working with sheep, and we tried to sort of get something together where we might do something that was very clinically relevant in a large animal model, because it's very hard to study how PMOS develops when it's already developed in women with PMOS. And what we are able to do is look at the very early stages, and that maybe can allow us to try to change its trajectory. That's one of our major goals, is to say, is there something that we can predict that means that somebody is going to develop that? How can we pick it up? And is there something we can do that is going to stop that whole process happening? And one of the things we've picked up is there might be some opportunities postnatally.
Yeah.
I think that the gold for me as a basic scientist to work with a clinician is that, as a basic scientist, I could go down a rabbit hole that has it's maybe very interesting to me scientifically, but could have questionable relevance to anyone else. In fact, I do remember Colin in our early days meetings describing some of the things I was talking about as worthy science, but who cares? and actually, that's been really, really useful because Colin can bring to the table what really matters and what matters to patients. And ultimately, that's why we're doing this. We're not doing it, or I'm not doing it to publish papers or for any recognition. Ultimately, I think as scientists, we're all doing this to the betterment of people. And so that clinical anchorage for a basic scientist is absolutely invaluable.
Yeah, yeah. And has there been any particularly memorable moments in the lab or during your experiments over the years, at least ones that could be shared with the general public?
That was the problem there.
I think that the biggest memorable moment was that we decided that one of the reasons that women with PMOS had problems with obesity is they don't burn off the same amount of calories. So you give them calories and they don't burn them off, and people without it burn them off. And one of our collaborators had previously shown it's because they have reduced thermogenesis, which is energy expenditure after you've eaten. So when you've had a big meal, if you don't need it all, you just burn it off. You feel a bit hot and sweaty afterwards. And those with PCOS aren't able to do that to the same degree. And what happened was that we thought maybe our sheep might do the same thing, and we got very excited when we discovered that they did exactly the same as women with PCOS.
I mean, frighteningly similar.
It was, and we tried to think, well, how do we sort that? And we decided that we were going to try to sort of increase the insulin signaling in the brain, because it was all about the brain. And what happened was we got our sheep and we gave them a spray in the nose, and that's going to increase insulin signaling in the brain. And our idea was that would help them burn off calories and burn off a lot more calories with eating without that. And we did it. We had 12 volunteer sheep that did that experiment. And what happened was that we got all these huge data points because Mick had all put these little implantable thermometers, and we were getting all this, and we had about 4 weeks worth of 1 minute temperatures.
Oh,
and we had
wow.
to sort of so there was a huge amount of data for all 12 of them. And I sat down one day and I thought, right, I'll check this one. And I got it all sorted out and checked, and I hadn't done anything. And
So that's that then.
And I thought that was so depressing that we'd done that.
It really was.
And then what happened was
at this stage I'd burned through 2 laptops.
With the sheer amount of data that was coming in.
Well, because the first time around, the data loggers that were implanted in the sheep, you needed to connect them directly to a laptop. And you try getting a sheep to stand still while you download their data. So.
and what happened was it just happened to be that I had a spare afternoon and I thought I'll just test the other ones. And what happened was that every single other of the 11, it worked beautifully. And I'd just chosen the first one to do, and it hadn't worked at all. And then I remembered that when we did the intranasal insulin, one of the sheep sneezed immediately afterwards. And I just, by chance, chosen that. And so I think that perseverance, in not giving up when you get an experiment that you think hasn't worked, and doing the proper analysis. But that one moment, I remember I was sitting in an airport, just finishing it off. And then I remember just emailing a graph to Mick saying it works. Oh. And that's great, because you know that you are the only people in the world at that time that know that works. It's quite exciting. Yeah.
But that research finding was almost completely hidden by a single sheep sneeze.
Yeah. It was indeed.
So why sheep then? Because I think a lot of folk watching or listening will be familiar with using mice and modelling human diseases. So what's the benefit of working with sheep?
Well, sheep are just either lovely and they have a developmental timetable, if you like, during the life inside mum that is very, very close to what we are. If you think about a rat when it's born, quite a lot of a rat's development, for example, pancreatic development, occurs after it's born. So that development is being influenced by the big world around us. Whereas in humans and in sheep, they are very well developed before birth inside mum. So that's one thing. The ovary is probably a little bit more similar in a sheep to a human than it would be in a rodent. So they just make a really good model. And they're big. And you can do a lot with them. And they're lovely animals to work with.
Yeah. And in terms of the, working with sheep, what are the kind of challenges of that? And do you ever get any negativity around working with?
I mean, our sheep have, I would say, a very, as far as sheep go, an enviable life. They have a long, happy, healthy, incredibly well cared for existence. And so, that's one thing about it.
And like in any form, a patient can agree to a study or disagree to a study, and sheep can't. So the whole process of getting the ethical approval to to do these things is very, very robust. To take it from there. I mean, obviously, one of the side effects is that they're hard to catch sometimes. And if they decide they want to headbutt you, they can headbutt you.
Yes, I had an interesting experience. I helped a colleague when I was working in Dublin who was looking at circadian rhythms, and we were collecting blood samples from sheep during the night, but we couldn't put the lights on because that might affect the expression of the genes. So trying to catch 80 sheep with nothing but a green torch on my head, that was quite fun. But I agree with you, Mick, they're such sweet, inquisitive animals to work with, and as you say, it's interesting that they're so similar in terms of human pregnancy and that kind of thing.
The downside is obviously they're also very expensive.
Well, that's it. So much bigger house is needed for sheep than mice. So coming back to that idea of kind of the fetal origins of PMOS, you both mentioned the male hormones, the androgens, and it seems like exposure to high concentrations of androgens during fetal life is potentially one of the main drivers. So I'm thinking maybe for the perspective of women listening to this podcast who might be thinking, well, how do I know if my unborn child is going to be exposed to high androgen levels? Like, I guess, how far back do we go to work out what's driving this?
We don't know. No. And that's the crucial thing. We know that we can recreate all the features by giving the mother a little bit extra male type hormone in the middle of pregnancy. We know that there is some evidence that that's what happens in humans, but there's not been any really good studies that sort of have correlated the levels of hormones that have been exposed in the mother or the fetus. There's hints that it's happening, but the whole thing about it is that if you are a woman with PMOS, you don't automatically have a child with PMOS.
Right, yeah.
And if you're a woman without PMOS, you might have a child with PMOS. So it's not classically genetic.
Yeah, I mean, I guess that's comforting. And
I mean, it does run in families, but it's not immediately predictable.
Yeah. So what would you want anybody with PMOS to know about the condition, or to know about what research is currently happening and potentially what developments are coming in the future?
I mean, the thing that I would want somebody to know about is, in a lot of women who come to me have been told in the past that they will struggle to get pregnant or might not get pregnant. And I think that the crucial thing is, as far as I'm concerned, is that every now and then an egg will be released and you won't have the luxury of knowing when that's going to happen. And so therefore it is very important to use contraception if you don't want to achieve a pregnancy. And most women with PCOS will live as many pregnancies as they want. They might need a little bit of help, but we have got incredibly efficient ways of making somebody grow and release eggs normally without needing to do complex things like IVF. The biggest challenge is that there are some weight limits to that treatment, and one of the big things is to make sure that weight loss is focused, and that's why weight loss has been a big element of our research.
Yeah,
but I think that the previous name has probably, this is just my opinion, but it's probably focused attention on the fertility side of things, which is great because it's absolutely necessary. But I think now what I would want people to know is that there is a huge amount of active research going on worldwide to actually try to tackle all the other issues, the weight gain, the aberrant hair growth, and all that type of stuff. So I would just want people to know that it's not being ignored, that there is a lot of work going on.
Yeah, and as you said earlier, Mick, they could potentially be driving the fertility issue. So if you can tackle one aspect of the disease, you might end up actually having benefits all round.
I found it very interesting at one of the charity link-up that we did when we were talking, and people were talking about their lived experience of PMOS, that actually what people were talking about was the weight gain, the if you like, the metabolism side of things, just as much as they were talking about the fertility side of things.
Yeah, and I suppose, correct me if I'm wrong, but up until fairly recently, that's probably been the aspect that's been harder to address with treatments compared to the fertility stuff, because you were saying, Colin, there's lots that can be done there.
I mean, I think that it's very hard for somebody to go to the doctor and then for them to say, well, go away and lose some weight when they know that their body behaves differently from other people's body. And I think that knowledge and focus is something that I think is important. I mean, we also know that because they've got a higher level of the hormone of storage, those with PMOS, they need to eat in a slightly different way. But they need to not skip meals, because as you skip meals, the next time you eat, you store more
gets stored.
And front loading the calories so that you're active after your calories, rather than taking most of your calories in when you're not being active either, so it all gets stored. But obviously, the new generation of weight loss medications is going to be helpful, and I think there will hopefully be more to come.
So what are you working on right now then?
Well, we've just released a paper that shows that we can't necessarily, certainly in our preclinical model, blame the ovary for all of the male-type hormones, because the adrenal glands seem to also be producing it. And that's reflected in, and Colin will correct me if I'm wrong, but that is reflected in the clinical population as well, of excess adrenal androgens. So we've shown that we can attribute that back to the early life as well. And the work that Colin talked about in terms of the insulin signaling and the nasal spray, I won't steal his thunder, but we've just done that in the human population as well. And it worked.
And the crucial thing about it is that it works. And actually, interestingly, they burn off more calories than even the controls did when they got some extra insulin. And so that makes a really exciting new way of looking at it. Does that mean that if you did a nasal spray of insulin, with every time you eat, do you lose weight? How does that link in with GLP-1s? And when all these every time you get an answer to something, you've got more questions. But it was been really nice taking data that we developed in a sheep model, taking exactly that into humans and finding that we have discovered something in the sheep that works in humans.
In the human. And I mean, timeline-wise, from the sheep study to the human study, how long are we?
So what we've got proof of efficacy, proof of concept. Sorry, what we need is proof of efficacy, and so therefore that's a long way.
Still a long way away.
Forward,
That's good. I mean, I think what I'm hearing is that there are lots of options for women who have PMOS, and that there's potentially some better things coming down the line. So would you say the outlook is maybe optimistic?
I hope so.
Yes.
I hope so. Yeah. And I think that one of the big things that's going to happen is not so much about new treatments as new understanding. And the people that those with PMOS go to see might have more of an understanding and be less dismissive.
Yeah, that's great. Well, I have one last question for you both before we wrap up, and it's the same question that we ask everybody. What is the one thing they didn't teach us in sex ed that they should have?
Well, I mean, I went to school last century, so I'm not sure that I got any sex ed. To be honest with you.
So everything is your answer.
So everything, yeah. Yeah, I don't know.
I think the thing that sex ed focused on was not getting pregnant, and that's, I think, is very important. But I think that people don't realise that as you get older, it becomes harder to get pregnant. And there's nothing worse, when I see patients in a fertility clinic where the female partner is 43 and they've decided it's now time to try and can't get pregnant because there's been aging of the oocytes and a reduced number of that, and the quality is not. And I think that people think that IVF is a panacea, and I think that the fact that IVF doesn't treat age-related fertility decline is important.
Yeah, I mean,
remember.
that's certainly something I've been reading and seeing a lot about in the media, is this kind of idea of leaving things a bit too late.
Yeah.
So
Well, it's hard. You have to be at the right time
that's
and
it.
things like that. But it becomes challenging, you know, when the options for fertility kind of. Interestingly, however, those with PCOS tend to be like a fine wine. Their fertility improves with
Is the
age.
age. That is very interesting.
I do think it's probably going to be, in the long run, with the benefit of hindsight, easier to change the way we live in society than it will be to change biology
Yeah.
in
Yeah.
terms of when people start families.
Nice. I mean, there's the biological aspect, as you say, but so much of it is driven by social environment, when you meet your partner, having enough money. You know, we could sit here for another hour and talk about all that, but at least, I guess, the biological side is in good hands with you too. So thank you very much for giving us your time this afternoon. It's been really interesting, I think quite timely with the new name change from PCOS to PMOS. So maybe you can come back in a couple of years and tell us about the new
next stage.
developments. Yeah,
Absolutely.
great. Thanks very much.
Okay, it's been a pleasure.
Thank
Thank you.